Hello, class. This is Marie Moran. I'll be talking to you about HM2030, Week 2, Part 3, Rural Practice and Keeping Physicians In. Access to high-quality healthcare services for rural Americans continues to be dependent upon an adequate supply of rural physicians. While efforts to meet shortages in rural areas have improved the situation, there continues to be a shortage of physicians. Although current data is not always available to access the magnitude of the problem, and the variation exists between on differing definitions of rural studies based on the demand to hire physicians by hospital physician groups or based on the number of individuals per physician in a rural area continue to indicate a need for additional physicians in rural areas. A balanced and cooperative effort among those involved in medical education is needed to promote rural practice. This includes increased recruitment of medical students from rural backgrounds, actively teaching of skills needed in rural settings, both at the academic medical center and the community level, as well as providing necessary funding for rural medication education on the federal, state, and private level. All need to work together to provide a support for training future rural physicians. Family physicians comprise just under 15% of the U.S. outpatient physician workforce, yet they perform 23% of the visits that Americans make to their physicians each year. In rural areas, an even greater proportion, about 42% of these visits, are to family physician offices. Possessing a broad range of skills, family physicians provide comprehensive and irreplaceable care to small rural communities. A 2001 study from the Robert Graham Center for Policy Studies in Family Medicine and Primary Care indicated that if family physicians were removed from the almost 1,600 rural U.S. Counties that are not primary care health personnel shortage areas, 67.8% of those counties would become primary care health personnel shortage areas. Despite the enormous contributions that family physicians make to rural populations and despite a reported surplus of physicians in the United States, the country's rural areas have been medically underserved for decades. While statistics on the exact number of rural Americans varies with the definition of rural and the data collection method used, the latest 2000 United States Census data has determined that about 21% of the U.S. population lives in rural areas. However, rural physicians comprise only about 10% of the total number of working physicians in the country. Using the new model of practice espoused by the Future of Family Medicine Project, it is estimated that a reasonable physician to population ratio should be 1 to 1,200. In the U.S. as a whole, there's one primary care physician per 1,300 persons, while in rural areas, the ratio is one primary care physician per 1,900 persons and one family physician per almost 3,000 persons. In the most rural counties, those with a community of at least 2,500 people, but no town over 20,000, close to 30,000 additional family physicians are needed to achieve the recommended 1 to 1,200 ratio. Sparse population, extreme poverty, high proportions of racial and ethnic minorities, and lack of physical and cultural amenities characterize rural communities most likely to suffer from a shortage of physicians. This persistent, intractable shortage of physicians in rural communities means that many communities struggle continuously to retain physicians. An April 2008 publication generated by the Robert Graham Center traced emergency room attendance based on Medicare claims from 2003. Overall, 75% of the claims were for care by board-certified emergency physicians. Most of the rest were seen by family physicians and general internists. However, emergency physicians saw only 48% of the rural and Medicare emergency patients. The more rural the location, the more likely the patient saw a family physician. In the most rural communities, the likelihood of seeing an emergency physician drops fivefold, while the odds of seeing a family physician increases sevenfold. The unique concern of rural emergency healthcare delivery must be considered in the training and recruitment of family physicians who will practice in these areas. Although recruitment and retention of rural physicians are often discussed in tandem, the factors that make a physician likely to choose rural practice are actually quite different from those that make a physician likely to stay in such a practice setting. Even a successful recruitment effort may not result in the addition of a family physician because the physician may have such a hard time adjusting to rural life that he or she leaves soon after arriving. Thus, it is important to deal with each issue separately. Programs that help rural family physicians become successful and stay satisfied with their choice have been developed. Ideally, rural-based family medicine residencies or departments with an emphasis on training physicians for rural practice could work with area health education cooperatives or other community-based groups to help communities develop such programs. Community physician preceptors can serve as role models for residents and as links to rural communities. Finally, although a complete review of these issues is beyond the scope of this paper, continued welfare reform and changes in Medicare and Medicaid payment policies that result in more equitable payments to rural hospitals and physicians would likely have a positive effect on retention of family physicians. Recruitment. Two of the strongest predictors that a physician will choose rural practice are specialty and background. Family physicians are more likely than those with less general training to go into rural practice, and physicians with rural backgrounds are more likely to locate in rural areas than those with urban backgrounds. Other factors associated with increased likelihood that a physician will choose rural practice include training at a medical school with a mission to train rural physicians. Such schools are more likely to graduate students who go into rural practice than schools that do not have a rural mission. There is, however, evidence that physicians who go into a rural practice after having been trained at a school that does not have a rural mission tend to stay in rural practice longer. Osteopathic training. Osteopathic medical schools have a long tradition in rural communities, and physicians who are trained in osteopathic medicine are more likely to select family medicine as a specialty than those trained in allopathic medicine. The difference between the two is the osteopathic doctor is going to have OD behind his name, and the allopathic doctor is going to have MD behind his name. Training that includes rural components, rural rotations, other rural curricular elements in medical schools and residency training are critical to keeping students who have an interest in rural practice from looking elsewhere. And participation in the National Health Service Corps Scholarship Program is a big indicator for the recruitment. Unfortunately, data from recent years shows that medical student interest in both family medicine and rural practice is actually declining. And although many physicians clearly enjoy rural practice, most physicians show little or no interest. Some proposed reasons for this lack of interest include admission of fewer medical students from rural backgrounds, less institutional or school commitment to meeting the needs of their state or locality, the negative effect of a medical school's vision of a research institution that creates physician scientists of subspecialties, as well as a perception that family medicine is a less intellectual pursuit. In addition, as students face higher debt loads, there is a belief that family medicine, especially in a rural practice, will not be successful enough to resolve these debts in a reasonable time. Because of these issues, some have suggested that the solution to the problem of rural recruitment is to expand the payback programs such as the National Health Service Corps. Certainly, state and federal loan payback and scholarship programs provide much needed physician manpower for many rural isolated communities. However, more recent evidence also supports the need to target students from rural backgrounds in the medical school admissions process. It also highlights success of nurturing and sustaining interest in rural practice by providing students and residents with early and frequent exposure to rural practice settings. Finally, the recent increase in the number of women graduating from U.S. medical schools could further diminish the supply of rural physicians, since women have historically been much less likely to go into rural practice than men, although it does appear that a higher proportion of recent women family medicine residency graduates are going into rural practice. One explanation for the historically low percentage of women in rural practice is the difficulty of meeting the needs of male spouses of physicians in rural areas. It is possible that a higher percentage of two-physician or other non-traditional partnerships may account for the recent increase in rural female physicians, although two-physician couples can have difficulty fitting into small call groups in isolated areas because both prefer to be off call at the same time. Women physicians may be particularly desirable to rural communities, making this a positive development. Conclusions: rural communities in America need more physicians. The best way to fill this need is to increase the number of students from rural areas and other students committed to rural and family medicine that are enrolled in medical schools. Physicians and community organizations from rural areas need to urge their state medical schools to give priority to students from rural backgrounds. Family medical faculty members should be part of medical school admissions committees so they can advocate for the admissions of these students. But increasing the number of rural-oriented students who enter medical school is not enough in itself, nor is simply increasing the number of physicians who begin rural practice. To support the students in their commitment and to promote retention of rural physicians, we need strong family medicine departments and rural-based curriculum elements in all medical schools. We need residency programs designed to teach the clinical, social, and interpersonal and management skills needed to be successful in rural practice. These residency programs themselves also need support. Groups such as the Accreditation Council on Graduate Medical Education and the Residency Review Committee need to make special accommodations for rural-based programs. Barriers to accreditation for rural programs persist in despite of the demonstration of the success of these programs in getting physicians into a rural practice. More rural health care services are still underpaid, threatening the viability of rural training programs as well as physician recruitment and retention. Government action is needed. Federal and state agencies that fund medical services could more actively support rural physicians. Finally, family physicians should actively support the AAFP and the National Rural Health Association and other groups that advocate for the rural physicians. Additionally, the AAFP will continue its ongoing support and outreach to rural family physicians, such as the recent formation of the Work Group on Rural Health Issues and an online community through AAFP website for networking and sharing between rural physicians. Additional services could include a mentorship program between established rural physicians and the residents and new physicians considering or planning to practice in rural settings. Rural Americans are a population group that experiences significant health disparities. Health disparities are differences in health status when compared to the population overall, often characterized by indicators such as high incidence of disease and/or disability, increased mortality rates, low life expectancies, and high rates of pain and suffering. Rural risk factors for health disparities include geographic isolation, lower socioeconomic status, higher rates of health risk behaviors, limited access to healthcare specialists and subspecialists, and also limited job opportunities. This inequality is intensified as rural residents are less likely to have employer-provided health insurance coverage, and if they are poor, often are not covered by Medicaid. Federal and state agencies, member organizations, and foundations are working to reduce these disparities and improve the health and overall well-being of rural Americans. Some organizations provide funding, information, and technical assistance to be used at the state, regional, and local levels. The fast natural disaster finance relief options. So, federal assistance is just one way to get financial help in a disaster. We know that recently there's been a lot of disasters, such as hurricanes and fires in our country, from forest fires and earthquakes to hurricanes. Bombs, cyclones, natural disasters can take a serious financial toll. The federal government offers financial relief to individuals and businesses that have been affected by natural disasters. And FEMA, for example, provides financial help for things like housing and basic living expenses. The Small Business Administration extends low-interest disaster relief loans to businesses, as well as renters and homeowners located in areas affected by declared disasters. But those funds can take time to trickle down, which may not be helpful if you need financial relief now. There are, however, some other options you can turn to for financial help when a natural disaster strikes. Mortgage assistance. Staying in touch with your mortgage lender is a must if you've been through a natural disaster or any type of financial hardship. Zach Reese, a certified public accountant and small business owner of Atlanta-based Colony Roofers, told the balance via email. Your mortgage relief options may hinge on what type of loan you have. If you have a Fannie Mae or Freddie Mac guaranteed home loan, for instance, you may be eligible to have your payments suspended for up to 12 months, or have late fees or penalties waived, and have any delinquent payment reporting to major credit businesses suspended. Similar options also exist if you have an FHA loan, a USDA loan, or a VA loan. With all three, you'll need to contact your mortgage lender. Before agreeing to forbearance, to deferment, or any other changes to your mortgage repayment plans, read the fine print. Specifically, look for any mention of how interest may accrue on the loans and whether any lump sum amount or balloon payment is required to cover payments that are temporarily suspended. Crowdsourcing or crowdfunding is another option for raising money quickly in a disaster. Sites like GoFundMe, for example, allow you to set up a campaign and accept donations from friends, family, or even strangers. And this money does not have to be paid back. Peer-to-peer loans are another option. For example, Lending Club allows you to take out personal loans that are funded by one or more investors. It's possible to get approved and have your loan funded in a matter of days. Keep in mind, however, the peer-to-peer loans need to be repaid with interest. So even though you may be getting short-term financial relief, you could be creating a long-term debt obligation. Timing may also be an issue since you may only have a specific window in which to fund your loan request. Crowd-sourced loans can be a fast way to get awareness to your situation and find interest-free financial relief, but only if you're able to raise the amount you need in the given time, Reese said. When using a crowdfunding platform or a peer-to-peer lender, be sure to review the service fees you might pay to launch a campaign. And of course, check the interest rates and fees associated with the loan. Personal loans can put a lump sum of cash in your hands that you could use for virtually any purpose in the wake of a natural disaster. For example, you might use a personal loan to pay your bills if you're unable to work, cover emergency housing if you're still waiting on assistance from the federal government or on your insurance company, replace lost or damaged personal necessities such as toiletries or clothing, pay boarding expenses for pets if they're unable to remain with you in the temporary housing. Personal loans or even a credit card could be helpful for covering month-to-month expenses following a natural disaster, Ethan Tabb, CEO of Loanery, told the balance via email. Similar to crowdfunding loans, however, it's important to consider the APR and fees you might pay. If you're looking for a personal loan to help out after a natural disaster, be sure to comparison shop. You might start with your current bank or credit union, but you may also want to look online lenders to see who offers the most favorable rates and terms. State and local government programs. In addition to federal programs, you may be able to get financial help following a natural disaster from your state or local government. At the very least, state and local agencies may be able to help direct you toward the organizations that can provide the help you need. The kinds of help that may be offered include temporary housing assistance, help with paying utility bills, medical care assistance, food assistance, and legal aid. Nonprofit organizations and charitable organizations can be another source of immediate relief after a natural disaster. Some of the agencies that offer help include Red Cross, All Hands and Hearts, 210 Footwear Foundation, Samaritan's Purse, Everest Effort, and AmeriCares. These types of assistance you can receive may vary. Some organizations can provide financial support. Others may take a different approach. Everest Effect, for example, helps people in need to get basic hygiene and household items following a natural disaster. When looking to nonprofit organizations for help, don't be afraid to cast a wide net. You're allowed to reach out to multiple places to get help. You're not limited to just one place, Lonery CEO Top said. And once you're approved, get as much help as you need. 401k hardship withdrawal. If you have money in a 401k, tapping into it via a hardship withdrawal could be a last resort option in a natural disaster emergency. The IRS allows for hardship distributions from a 401k when certain conditions are met. For example, having an immediate and heavy financial need, withdrawing only what is needed to meet that need. If your 401k plan allows for hardship distributions, you could get cash at hand quickly. But keep in mind the tax consequences. If hardship conditions are claimed but you do not actually qualify, a 10% early withdrawal penalty is assessed, said David Gottlieb, wealth advisor at Eisner Amper Wealth Management and Corporate Benefits. In other words, you must be sure that you're eligible for a hardship distribution before taking one. Additionally, hardship contributions are taxed as ordinary income, which could result in a higher tax bill. The upside, said Gottlieb, is that unlike a 401k loan, a hardship distribution loan or hardship distribution doesn't have to be repaid. Before taking a 401k hardship distribution, consider using an online calculator to estimate the tax cost at early withdrawal. How to request help if you need financial assistance or any help of any kind following a natural disaster. Connecting with the right resources may seem overwhelming. In any natural disaster situation, the federal government urges you to contact FEMA first. But beyond that, you can work down the list of resources included in this article and contact your mortgage lender and any other lenders or creditors that you may want to seek relief from. Consider whether you want to set up a crowdfunding campaign or apply for a crowdfunding loan. Compare interest rates for personal loans online. Connect with your state's emergency assistance agency or Department of Health and Human Services. Search for national and local nonprofits that provide disaster relief. And talk to your Human Resources Department about whether 401k hardship distribution is an option. Hardship criteria. Uh, Certain medical expenses, costs relating to the purchase of a principal residency. In other words, you can't make a hardship withdrawal to buy an investment property or vacation home. It would only have to be for a principal residency. Tuition and related educational fees and expenses, payments necessary to prevent eviction from or foreclosure on your principal residence, burial or funeral expenses, expenses for the repair or damage of your home, expenses including loss of income incurred if you reside in a FEMA designated disaster area. So these are criteria for the 401k plan, a hardship withdrawal. Taxes affecting the 401k hardship withdrawal. You will pay taxes on the amount you take out in the form of a hardship withdrawal. In addition to regular income taxes, you will likely pay 10% penalty tax. You may be able to avoid the 10% penalty tax if you meet one of several exceptions. If you are disabled, your medical debt exceeds 7.5% of your adjusted gross income, or if you are required by court to give more money to your divorced spouse, child, or dependent. If you don't qualify for an exception to the penalty tax, you need to plan that at least 30 cents on every dollar you withdraw will go towards taxes. So, for example, if you withdraw $1,000, for instance, you might only get $700 after taxes. If you have other resources, such as an emergency fund, that could be used to meet your financial needs, then it is best to use those assets first. Use a 401k hardship withdrawal only if it is your last available option. Proof of hardship. To qualify as a hardship, you will need to explain your situation to your 401k plan administrator. Most of the time, they can easily determine if your circumstances qualify as a hardship, but some 401k plans may require you to present some form of documentation. Ask your 401k plan provider what they require as a proof of hardship. After you take a 401k hardship withdrawal under prior law for 6 months after you took a 401k hardship withdrawal, you were not allowed to make contributions to your 401k plan. That 6-month suspension has been eliminated effective January 1st, 2020. You are not allowed to pay back the amount of the hardship withdrawal, but you can continue to contribute up to the maximum 401k allowable contribution limit for the year. When you borrow money from your 401k plan, you can pay it back over 5 years, and the interest you pay goes back into your account. At the time you take a 401k plan loan, you will not pay taxes on the amount you borrow if the loan meets certain criteria. If you do not pay back the full amount of your borrowed amount according to the repayment plan, then any remaining loan amount will become a taxable distribution to you and may also be subject to a 10% early withdrawal penalty if you are not yet of age 59 and a half.